Hello, this is Clyde Yancy with theheart.org, about to entertain what I think will be a very provocative discussion about our contemporary assessment of the whole space of guidelines and the generation of clinical practice guidelines, and particularly the interface of industry in the generation of those clinical practice guidelines. To have this discussion, I'm delighted to be joined today by Neil Moat, who is a cardiac surgeon at Royal Brompton Hospital in the UK. Neil, thank you for being here. Delighted to have the European perspective here. And my good friend and colleague, Harlan Krumholz, professor of medicine from Yale, is here to also contribute to this discussion. So let me just put it out there so we can get right into our discussion. All of us believe that clinical practice guidelines are absolutely necessary to allow us to understand how best to adjudicate the available evidence, convey that evidence to the practice community, and set statements that inform how best we should practice. Guidelines are imperfect. Let me say that again. Guidelines are imperfect, but as they connote, they represent statutes against which we should target our therapies. Now, it's very important that if we give them that kind of primacy, we need to understand very clearly whom it is that's writing the guidelines and how their assessments and interpretations of the data might be influenced. And that gets us to this space of whom it is that's related to industry and how is it that they are able to contribute to the process. Recent statements, as Harlan knows, that have been in the U.S. literature have suggested that an inappropriate percent of people who write these guideline statements are aligned with industry, but more recent changes for at least the ACC, American College of Cardiology, American Heart Association process have gone a far way towards making that possibility much less likely to occur. But nevertheless, it's out there. We have to wrestle with this influence of industry potentially in the generation of clinical practice guidelines. So let's start with some statements that reflect your viewpoints. Harlan, why don't you go first?
Well, it's a complicated issue. I think that we are well served by good, strong guidelines. The guideline process has certainly made a lot of progress. Cardiovascular medicine has led. But I think we have a ways to go. And this isn't just a simple thing about, whether we exclude or include people who've got, industry relationships. It's a complex topic. The nature of those relationships may matter. The degree to which we have created a guideline process that is reliable. And by reliable, I mean that if you brought together another group, would they come up with the same things? I mean, how much discretion is there in the development of guidelines, and how confident can we be that another group would come up with the same thing? And the degree to which there's a lot of discretion not only undermines the guideline process, but allows sort of these influences to come in. I've never seen or experienced in all my time on the guidelines someone come in who I feel had an agenda to promote industry, but I have seen people with very tight relationships with industry in various ways promoting messaging that I think maybe advertently or inadvertently sort of gets into the discussion in which they've had some influence. And we need to look at the big picture. That is, I think this is just one aspect of the guideline process, which is what are your associations? And I may be, in my mind, not as important as thinking holistically about how strong is this process and how can we make it better.
So if we kick this up to another notch, isn't what we're really discussing the absence or presence of bias in the guideline process? And bias can be sourced from a number of different ways. It's not just relationship with the industry. It can be an intellectual bias. It can be a professional bias.
Well, it's a question of how much we're going to dig. I mean, one of the big biases, I think, is publication bias. And when we looked at the Vioxx case, this had nothing to do with the guidelines, but we looked at the Vioxx case, we saw that about half the studies never made it out into print. And when you looked at those studies, you could have found 3 years before Vioxx was taken off the market that there was cardiovascular risk associated with it. So the degree to which, are we able to invest in our guidelines so we're able to do a broad search of FDA documents and all what's in and out of the literature? I mean, how can we bring all this to light so we can really understand what the deal is? That's part of it. And another part is, there are people coming in with their own pet theories, whether they're on industry or not, where they're pushing new products because they believe that they're innovators, they're early adopters, or how can we bring some balance? And the degree to which we have clear, firm standards in our guideline process, the degree to which it'll be reliable and people will be able to trust it.
So 3 statements already that are relevant. We do have questions about relationships with industry. We do have questions more generically about bias and freedom from bias. And then, as Harlan brings up, and we don't have time to delve into this, the evidence base. How do we amass it? How do we adjudicate it? How do we capture all of the pertinent evidence and don't deal with what is favored in publication?
Yep.
Tell us about the European experience.
I think the things that you're talking about transcend geography, really. I think that clearly we all have bias in our views, and I think industry, as you've alluded to, Harlan, is only one aspect of what might influence our decision making. I think that one of the difficulties, I think, in creating guidelines committees of leaders and key opinion leaders is those people are almost certain to have relationships with industry, have their own research programs, have a strong publication record. So they are bound to have elements of intentional or probably largely unintentional bias. I think perhaps the key thing, two things. One is you alluded to was the whole process perhaps needs to be structured in a better way to try to ensure that there cannot be any systematic bias of any kind. And the second is really the composition of the committee. And I think if the committee is composed, the writing committee is composed in an appropriate way, one can balance out any bias that may come from one type of professional group. So I think those would be the sort of overarching principles I would...
Yeah, and I think that there are a couple ways that I've sort of seen this come in. I mean, I've seen individuals who are out promoting products be able to, come in with strong opinions. I've also seen people who've led trials in the area. Now, it's this funny kind of thing. You'd like to incorporate them into that process, but when they're in the room...
They have the content expertise.
They have content expertise, but I wonder if they shouldn't just come and present to the committee. Because when they're a member of the committee, you naturally end up deferring to them because they're telling you all sorts of things that never got into print, and it's all hearsay. We looked at that and we found this and we found that. No, it's all well-intentioned, but it may not have been a systematic view, and you're left sort of deferring to them as opposed to having them present to the committee and be a resource, but not necessarily be one, because if they're on the committee, it's hard not to defer because they've got the knowledge.
I think it's important for us to really drill this down to where it matters to the rank and file clinician who's listening to this program, because the three of us wrestle with this professionally because this is part of what we do, but this is not what everybody does. Why should someone viewing this program care about the discussion we're having right now? Harlan, what is your viewpoint?
Well, because these now have great consequence, and they want, it's hard for anyone to keep up with the entire medical literature. When the guidelines come out, they want to be able to look at the level of support, level of recommendation, enthusiasm for particular actions, and feel confident that the people around the table were able to make fair judgments around the totality of information that's there, and that they're a wise group of people who are going to provide direction.
Yeah, I think that the clinicians who are watching this will be aware and to some extent rely or be guided by the guidelines in their clinical practice, and therefore it's vital that those clinicians who are involved in writing the guidelines produce unbiased, good, high quality guidelines for that much larger group of clinicians to be able to follow.
One thing I like is, at least in this country, is a number of people who comment on each of the guidelines. If we pass it through a lot of people, and I think that's a good process.
That's an excellent check and balance.
It's a nice check and balance.
I mean, I like Harlan's idea of somebody may be part of the bigger guideline group, but use their expertise. But perhaps when it comes to the final statement, they maybe should leave the group or leave the room.
But Neil, that's the important question, because people who put these committees together will argue with you that it's very difficult to find the content experts to write the kind of document that the viewership for this program would like to see, because it's a cut to the chase. These are the things we think you should certainly do. You shouldn't do these, and you might think about these others. And by the way, here's the evidence to support what we had to say. Those that put these committees together wrestle with finding the right mix of content expertise, because a lot of that content expertise, and this becomes, again, a more tangential argument, a lot of that content expertise already has a very evident relationship with someone who might have
But I think some of the most
bias.
important people are people, this is going to be my bent, but have the methodologic expertise who really can look, with great clarity at the studies and their soundness and what you can infer and what remains sort of uncertain. I don't know what you think about that.
I agree entirely.
So that means you've introduced, if you will, a fourth dynamic, because it's not just the relationships with industry, being clear of bias and understanding the evidence base, but now it's introducing much more strict methodological approaches, so that too allows us to weed out issues that otherwise we would not have caught in the past.
To inform the process.
To inform the process. Right. But now, can we not sit back and be somewhat reassured that particularly in this country, when we look at the adequacy or the compliance or adherence to which guidelines are followed and see the clinical outcomes track accordingly, that in fact is at least some support, some validation that the process, no matter how imperfect, is achieving at least part of its desired goal. Are you comfortable with that?
No, it wouldn't take much assurance from that. Most of those studies are studies that are saying, are addressing a small number of the recommendations that are in the guidelines. And I think the question for us, is our guidelines going to continue to contain Class C recommendations, or should we sequester them off somewhere else where these are our best guesses in the areas that we don't have evidence, but it's not really part of the guidelines, which are firmly evidence-based. Doesn't surprise me. People follow that evidence, we're getting better outcomes, but I think that doesn't assure me so much. The other issue is what the public thinks, which is what does it look like to the public, or can they be confident in these? And sometimes it's we're talking about what the substance of this is actually, but it's also going to be whether the perception of them, and that perception can also be important.
Yes, I think that it's going back to the process, isn't it? And I like your point about really having more people who are methodological experts at looking at studies and trials. Certainly, in my experience in Europe, those people tend to have not been around the table in large numbers in the guideline writing groups. So I think going back to it's the process that really needs to be addressed. I really don't think there is actually a lot of systematic industry-led bias in the guidelines, but you can see why there is a risk of that or perception.
Issue, yeah.
But so I think that suggestion as part of the process, I think would reassure people that there was independent people from really outside the specialist area who say, well, you're saying this about this trial, but actually you can't infer that from this methodology.
And we could be explicit too about things, because especially new drugs. I mean, should we give them the same range of endorsement when they haven't actually been tried in the overall population, but they've been shown in a trial? I mean, making these things explicit in the guidelines rather than have it be group to group decided. And I think we've made progress in the U.S. at least, with ACHA, trying to codify, strategies that improve the guidelines.
So let's do this. Let's wrap up. This is a great discussion, but we could go on and on. So each of you, give me your one most important take-home message about this process. What do you think is good about it, and what do you think needs to be modified?
Well, I would like to see us continue to aim to have more highly reliable guidelines with a strong methodologic input, with standardized review of the literature, with as much transparency as possible at how the logic was created. I'd like to see people who have strong relationships in the industry that we believe have strong content making presentations to the group, but not necessarily participating in the vote, being in a form of saying this is our resource group, which may represent, we'll purposely seek disparate viewpoints in a resource group that may make some presentations. But I think that we can still go ways to improve it. That being said, I'm very proud of the progress that's been made in the guidelines over the years and the people who've served on these committees. But as always, I think there's opportunities for us to elevate further.
Neil, take-home message?
I agree with all of that. I think Harlan said everything. The only thing, perhaps one extra little bit of reassurance, is that if there was some kind of audit process of the guideline writing process, so you took a certain proportion of the guidelines and you got another group to look through the industry, and you were able, therefore, to have some kind of...
We have some of that, actually, between the European and the U.S. guidelines.
De facto, we have that with Europe and U.S.
Yeah.
Well, this has been a fascinating discussion. The one thing that I would add to this is that the current process in the United States for cardiovascular guidelines, the American College of Cardiology, American Heart Association, is totally in sync with the themes that we're connecting on now. Transparency, really managing the relationships with industry carefully, looking for all sources of bias, trying to ramp up the substance of the evidence base that we're using, introducing new methodological strategies, and again, realizing it's imperfect, but realizing how important it is and how necessary it is for us to keep moving.
And I don't think we should mind that there are articles that question and raise these issues. We should welcome it because
absolutely.
We're trying to embrace how can we do better.
Absolutely. This is Clyde Yancy with Heart.org having a great conversation with two colleagues about something very important to all of us, the clinical practice guidelines. I'm delighted to have been joined by Neil Moat from the UK and Harlan Krumholz from Yale. Thank you very much for your contributions. Thank you for listening to us. I hope this has been informative.